All right, we'll go ahead and recommence. And first and foremost, the most important part is it is 3 p.m. and it's beautiful outside, so thank you so much. And we are going to, Ken Beckman and myself, going to do our very best to make this a great debate session of a great corneal pathology and scenarios. And with me to my left, I've got a very esteemed panel, Dr. Doyle Stolting, Dr. Renato Ambrosio, Dr. Raj Rajpal, Dr. Katie Hatch, Bill Trattler, and Dr. Raj Fogla. And our first speaker of this session is going to be Dr. John Kanellopoulos, the one and only, who will be discussing cornea crosslinking in 2018, which age is too young or old to treat, and other questions that we do think about as we gain more experience with crosslinking.
Good afternoon. Thank you, Elizabeth and Ken, and I want to thank the Cornea Committee for allowing me to speak to you today. I'm going to move this podium on the side because I've gained a few inches of height since last year. So these are my financial disclosures, and a lot of the things I'll be presenting to you today first are not FDA approved, some of them, and do involve the technologies mentioned here. We have been organizing the last 2 years a series of courses, pre-major meetings, to look on what I will be discussing with you today in more depth and depth. When and how should we cross-link? Now, whoever can answer this with accuracy is welcome to take over at least my practice, because we're still endeavoring in answering these questions. How do we screen about keratoconus? I'm going to try and cover this. What is the familiar predisposition of keratoconus? Because you if there's a strong predisposition, need to screen all the relatives of patients that you already have with keratoconus. How do we document progression? And this will become very important in the US, as there is going to be insurance reimbursement, and there is already, and they do require progression documentation. What is the optimal pediatric and adult CXL technique and potential complications? Now, how do we screen for keratoconus? It's unfortunate that most patients will seek help for keratoconus if the visual acuity drops. And we have increased evidence that visual acuity is a very poor screening method for keratoconus. Cornea imaging is essential, so do not rely, even for the most skilled of you, on slit lamp biomicroscopy, refraction, and acuity to pick up keratoconus. Cornea imaging is essential. Anterior curvature asymmetry indices, seen here, for instance, on sign fluke imaging with a pentacam, IHD and ISV, in very large case series that we publish, are essential in picking up early keratoconus and progression. I personally rely on cornea pachymetry maps as the most sensitive tool, and I'll speak a little bit about that. Epithelial mapping has become essential. We've published almost a dozen of articles along with other colleagues on how important imaging has become, and I will only show through these plethora of papers the epithelial maps available with anterior segment OCTs, which are much user-friendly and have become a very essential tool, at least in my practice. Thickness maps are available with, as you can see here, sign fluke imaging, and of course high-frequency ultrasound has been around but has not been widely clinically available. Here to show you examples, sign fluke imaging and how IHD, seen here, and ISV are important indicators, as well as epithelial mapping. This is a patient where, for instance, on sign fluke imaging looks relatively normal. For me, the pachymetry map seen down here on the right, on the left rather, is very suspicious because the cornea thins in a very steep manner, and it's not central to the cornea. It's not picked up by the very sensitive Bell and Ambrosio criteria. The topography looks a little bit suspicious. Cassini looks also a little bit suspicious. But when you look at the epithelial maps, I think no one can doubt that these are irregular keratoconic epithelial maps. The epithelium has responded, has remodeled, and is hiding keratoconus from the patient and from you. So this is a very sensitive method. If you have access to an anterior segment OCT with epithelial mapping, you become much more astute in picking this up. Familiar predisposition, very important for me because the literature so far shows a 12% familial predisposition. We're submitting to the literature work in over 500 families from Greece that have almost 100% yield in family members to be suspicious for keratoconus. And we feel that this is very similar for the Eastern Mediterranean Basin and the Middle East. So, in my opinion, keratoconus should be considered a family disease, and choosing LASIK versus surface ablation may become clinically relevant for relatives that you have that have keratoconus and want to have laser vision correction, and even in despite any clinical topographic sign of keratoconus. And I know this is going to ignite a lot of discussion. How do we document progression? Another very difficult aspect, because again, we're stuck through tradition, education, and custom to look at visual acuity and refraction. And these are very poor prognosticators of progression. You need to go back to the topography. If you're able to do comparison maps, they're very important. Ideally, thickness maps on side field imaging. OCT is more reliable in being accurate with thickness maps and epithelial mapping. I cannot stress that enough. What is the optimal pediatric or adult CXL technique? I need a couple weeks to elaborate on this, but I'm going to try and fly through this. The gold standard and the FDA-approved technique is epithelium off, the Dresden protocol, and that is definitely your safe harbor in treating ectasia globally. Now, there are several techniques. I'll speak a little bit about the Athens protocol, which is now globally practiced in a way of a customized partial, and I want to underline the partial PRK and cross-linking. It's not a refractive procedure. It tries to normalize the ectasia and stabilize the cone. Epithelium on, we're seeing a lot of work, a lot of new techniques, but it needs to be proved that it's effective enough. Of course, there's other techniques, intercorneal resegments. They have been combined with CXL. Tough to apply these in pediatric patients. Speak a little bit about combining topography-guided PRK. You can see how irregular these treatments are. We can, with a limit of 50 microns over the cone, you can treat very little of the refraction anyway. But in combining this with higher fluent CXL, you can get some very dramatic improvements in these very irregular corneas. You can see here a pre-op, a post-op, and the difference map. Dramatic flattening of over 10 diopters. Very difficult to get this with cross-linking alone. Well, these are the 10-year outcomes that we presented at the Academy last November. And this is a pretty reliable procedure. Of course, no surgery. This is in press. No procedure is perfect. We see a longitudinal continuum of flattening of Ks through 10 years with the combination topography-guided partial. Again, I'm going to underline the partial, PRK, and cross-linking. So you have to be very frugal on treating refractive error. And these are some of the results. You can see how we start. We reach a few years later, and some of these cases may continue to flatten through the years with dramatic flattening of the cone. So you need to underscore your refractive error correction. This is a case that over flattened. Of course, it's considered a complication, although on the stabilization of the cone, it's a great success because not only did it stabilize, but it really flattened the cone immensely. We've also presented the Academy results on pediatric CXL, which appears to be similar to our adult population. Very good long-term results in combination with PRK in those pediatric patients that were old enough, of course, to undergo a PRK procedure. Similar data long-term on continuing flattening of the keratometry. And again, some of the changes here. Potential complications, I'm going to close with these. Obviously, especially for pediatric patients, one of the concerns is bandage contact lens use. As we know, bandage contact lenses in general have a higher risk in pediatric patients. Delayed epithelial healing may be specifically difficult in pediatric patients. We have encountered some very late post-CXL scarring in pediatric patients, so you have to be aware that these patients may need long-term UV protection, and of course eye rubbing is an issue. This is a deep stromal scarring seen 2 years after an Athens protocol in a 14-year-old patient at the time, because he spent the whole summer on a beach in Greece, so very rare complication along with the delayed epithelial healing. So when to CXL? Early. For pediatric patients, I think that most international experts will agree when you diagnose keratoconus, it probably needs to be cross-linked. For adult patients, it's up to your clinical experience. Special attention to trisomy patients because they can progress rapidly. For those of you who do not have summer plans yet, I would invite you to the Aegean Cornea meeting in Mykonos this year at the end of June. And I thank you very much for your attention.
Thank you. John, thank you very much. couple of questions. What is the youngest age of a patient that you've treated? And with regards to the Athens protocol, do you always do simultaneous partial topo-guided and the high fluence accelerated time, or do you ever stage them?
Very good questions, and thanks for putting them up. The youngest that I've personally treated is 8, and it was a trisomy patient. Of course, we can all appreciate how difficult it is to make the diagnosis in younger patients, as they very rarely walk into the office with visual complaints. The parents have to pick it up. But I think that it's imperative, once you have keratoconus patients in your office, to educate them that the whole family needs to be screened, especially offsprings up until their 20s, because there may be, we've commonly seen worse keratoconus on the brother or sister who's even a few years older of a non-keratoconus patient who's 17. So it's very important. As far as the combination treatment, we have reported in the past that the combination treatment is synergistic, so we get more of an effect. Of course, the milder the keratoconus, the less of an incentive you have to perform a topography-guided PRK. So I think you have to gain experience in treating with PRK to be able to use this routinely. We do use this routinely over the last decade.
John, that was really, really informative. I have another question for you and the entire panel. We just asked about the youngest. I'm curious about your older patients. We tend to see the steepening and the progression slow down as patients get in their 50s. Can you comment on how you manage the older patients who may or may not even be progressing but can still get some flattening, and how liberal you are with going ahead and treating those patients? I'd be curious what the rest of the panel does in the 50 plus who are advanced and may not necessarily still be progressing.
Well, I think it's well understood that older patients progress less often, but we have to underline that. It does not mean that a 50-over-year-old patient will not progress. He's absolutely safe. And I think that once diagnosed with keratoconus, I would recommend patients to be screened every 2 years after 50, or if they have change in the visual acuity. But we do screen routinely cataract surgery patients, and I know that's the next subject, because then it becomes a treatment dilemma whether you're going to do straight cataract surgery or combine it with a treatment.
And then the question, and this is to everyone on the panel as well. So we're talking about different utilization of cross-linking, and with primary ectasia in the realm of keratoconus, we have a lot more data. In my own hands, anecdotally, and it may just be because I'm not doing it right, but I'll tell you, my post-LASIK ectasia, I don't have the same stabilization that occurs, and I certainly don't know what that information in like a pellucid marginal degeneration type of patient actually looks like as well. So from the panel, and Dr. what is your experience with efficacy of cross-linking in different types of ectasia or secondary ectasia?
Well, the problem with cross-linking in general is that it's a very generic treatment. We don't have the dose response down to a scientific level. So you can have variable response to cross-linking at the modes that we're using today on different patients. And yes, it is my experience as well that in iatrogenic ectasias, we do have more variable responses, from very strong to less optimal.
Liz, so one of the things, so usually when we're doing cross-linking, most people are usually putting the UV light centrally, but if you have pellucid, the weak spot is inferiorly. So one of the things that Michael Morokan spoke about is that in those patients that have pellucid where the thinning is inferiorly, you want to have them look up and over the light and treat more directly down in the thinner part of the cornea and treat that area, rather than just treating centrally, because you may miss the thinner, weaker part of the cornea with cross-linking.
It's a really good point that you mentioned, looking up and out rather than just moving the light down, because of the light won't be hitting tangentially, it'll be hitting directly on the area. That first question I asked before, I wanted to get some of your other input as well, as far as the elderly patients and how you manage them. If you want to just go down and start talking about it.
Well, in the adult patient, if you look at it, if somebody age 50, they have already got used to the vision, and if they are not visually symptomatic, so unless and until I see a documented progression, I don't think I go out and advise cross-linking on them. As compared to the younger patients, I think it's important that if they have associated any allergic eye disease, that needs to be treated and controlled first before you venture out and do cross-linking. So one of the questions that I wanted to ask John is that if you have a pediatric patient with active vernal conjunctivitis, what is the time duration between the treatment of the vernal disease and the cross-linking that you would like to give a gap?
Another very good question. The problem with vernal, especially at its peak in the spring, is that they can progress very rapidly. And the whole thing we're trying to do here is zero our cornea transplants for keratoconus. And we can do that with early diagnosis and early application of cross-linking. We do have the vaccine. We have to learn how to apply it. So we will not need to do cornea transplants anymore if we all take this into our practices. I would give at least 3 months on treating vernal, because of course you don't want the patient to be rubbing their eyes while they're recouping for CXO, but that's, I'm sure that everybody has his own technique on this.
One very good point. I think it's always important that we educate the patient not to rub the eye, because it doesn't matter if the patient does cross-linking, if it still rubs the eye, the effect will be just much minimal. It's one of the most important things for the patient that has keratoconus is to educate them not to rub the eye, not only treat the allergies, but not to rub the eye is very important, because rubbing is sometimes not related to allergy. Rubbing is related to other things like a habit or some type of tic that the patient has. So it's very important to tell the patient not to rub the eye.
I also just want to say, with speaking of regarding older patients, I think with pellucid, actually, you can see those patients progress much later. And so you see sometimes the pellucid patients in their 30s and 40s and 50s get progression, significant, and that's actually a really good time to cross-link them early, and then prior to before they develop cataracts. And I think I don't have an age cutoff where we say that these patients aren't going to benefit.
Great. Well, go ahead.
We just analyzed our results of 512 keratoconus and 80 ectasia with outcome measures of uncorrected acuity, best corrected acuity, Kmax, and high-order aberrations and coma. And by all these measures, and IHD and the other Pinacam indices, and by all these measures, we got a similar result in the two groups. So for us, the outcome was equal. I'd also comment about the issue of defining keratoconus and keratoconus progression. We know and have seen in our outcomes that Kmax is extremely variable. For clinical trials, we are now leaning toward comparison of those that gain Kmax versus reduced Kmax. We're seeing about 3 times as more reduction than increase, and we believe that a better measure of progression is based on both an increase in Kmax and a loss of best corrected acuity, because both are terribly variable, and we need to have a more reliable measure.
And Dr. Stoilting, was that epi-on, epi-off, accelerated?
Epi-on.
So if I can just comment, Liz, to your question about ectasia, I think certainly the best data that we have in a controlled study with a control group in the FDA data for the pivotal trials for approval, it was very clear that keratoconus patients flattened at a much greater level than the ectasia patients. But Ken, to just comment on your question also quickly, I think I agree with everyone else. Certainly, obviously, we want all of our patients to stop rubbing, but even the older patients, I think it is reasonable to watch for progression, perhaps a little more carefully in those, that we don't have to be as aggressive. But I do just take one note that I think 50 shouldn't be called old.
Absolutely. Well,
more experienced patients.
Going to this direction, I agree with Dr. Stoelting on the sense that the cross-linking for ectasia and for keratoconus tend to see the same results and the same variability. Probably the best patient I have with cross-linking is opposed to LASIK ectasia, but also many of them fail. And I think the main differentiation that you can get is in the flap. If you have a very thick flap, the cross-linking is going to be very limited. So I think it's very important to understand why the patient developed ectasia, and if you get the pre-op data, pentacam, topography is going to be important, but if the patient has a thick flap, I think you have to go to suturing technique instead of going to a just cross-linking. Maybe suturing and cross-linking later. Have a couple cases that I did that.
Great, that was a wonderful talk. Before we get on to the next one, I just wanted to again thank our sponsors, Alcon, Allergan, Avedro, Bausch & Lomb, Johnson & Johnson, and Shire. We always appreciate your support. Also, if you look at our schedule so that you don't panic, the very last section where it says case scenarios from 4:03 to 4:30 has actually been eliminated, so we've added extra time to the others, so we're really not running behind.